You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, instructor of medicine at Harvard Medical School and physician at the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Jacob Sands, a thoracic medical oncologist at the Dana-Farber Cancer Institute. Welcome to Medscape's In Discussion series on lung cancer. Today we'll be discussing neoadjuvant and adjuvant therapy for non-small cell lung cancer. First, let me introduce my guest, Dr. Benjamin Levy, a thoracic medical oncologist and associate professor at Johns Hopkins School of Medicine. Ben, welcome to In Discussion.
Thanks for having me, Jacob. Pleasure to be here.
So to start off with, let's talk a little bit about your personal journey. How did you end up in the position you're in? What led you into being a specialist in lung cancer?
Yeah, I think it's quite surprising to some people that I didn't choose lung cancer. Lung cancer chose me. When I finished my fellowship, believe it or not, I had been in the lab doing prostate cancer research. But at the end of the day, I got interested at the very last minute because of all the new targeted therapies that were coming out in lung cancer, and ended up taking a job as a thoracic medical oncologist right out of fellowship just at the very end. So I've been in the field for the last 12 to 15 years, and it's been very exciting for me.
Now, we're going to discuss perioperative management of non-small cell lung cancer. And there has been a ton in the last 10 years in the non-small cell lung cancer space with targeted therapies and immunotherapies related to metastatic disease. And we're finding that moving into the perioperative space too. But maybe let's just start at the base. Adjuvant chemotherapy really was the standard for a long time. Maybe you can just discuss that starting point.
Yeah, as you mentioned, I think we've learned over the past 10 years that adjuvant platinum-based chemotherapy for resected stage 1B to 3A patients does provide a survival advantage. You know, we've got multiple phase 3 studies that were done in the 90s that show, again, that when patients get adjuvant chemotherapy, specifically cisplatin-based chemotherapy, there is a survival advantage. Now, we have the LACE meta-analysis that was a meta-analysis of all these studies that essentially showed that adjuvant platinum-based chemotherapy does provide a survival advantage, but that survival advantage is modest at best. That essentially it's a 5% improvement at 5 years for those patients who got adjuvant chemotherapy versus those that did not get adjuvant chemotherapy. It's a modest benefit, but created the foundation for some of the newer therapies that we'll talk about in the perioperative space.
The further discussion on that in the perioperative space is essentially targeted therapies and immunotherapies. So let's start with targeted therapies. So we had the ADARA data, which was specifically related to EGFR specific treatment. Can you walk us through that?
Yeah, the ADARA study was a practice-changing phase 3 double-blind study that looked at patients with resected stage 1B to 3A, all harboring an EGFR sensitizing mutation, so exon 19 or L858R. Patients were given chemotherapy at the discretion of the treating physician and then randomized to osimertinib 80 milligrams a day for up to a plan of 3 years versus placebo, asking the question, does adjuvant osimertinib, a next-generation TKI, provide a benefit for those patients with resected EGFR mutant lung cancer? And I think all of us were surprised at the disease-free survival that we saw. Disease-free survival is not overall survival, it's a composite endpoint of either recurrence and or death. And the hazard ratio was a hazard ratio that we haven't really seen in a long time or ever. Hazard ratio was 0.21. These curves diverged very early on. The hazard ratio continues to go down the higher the stage, not surprisingly. And then we've seen early cuts on other endpoints like CNS recurrence. Not surprisingly, there are less CNS recurrences in patients who received osimertinib versus placebo. We haven't seen overall survival yet. I think that just based on the early cuts of CNS, we will see an overall survival advantage. It's also hard for me to believe that a hazard ratio of 0.21 in DFS won't translate into an overall survival. Nevertheless, without seeing an OS advantage, I think all of us have been adopters of this. We've been begging for better therapies in the adjuvant space based on the LACE meta-analysis, just showing a 5% improvement at 5 years for adjuvant chemotherapy. So this was a game changer for me, and it's exciting to be able to deliver this therapy for patients with resected lung cancer harboring an EGFR sensitizing mutation.
Yeah, the separation of the curves on this was really impressive. And you mentioned the intracranial CNS disease-free survival. That's really a subset kind of a chart there, but that graph is what we want cancer treatment graphs to look like. It is impressive how much across the top, essentially, that osimertinib arm looks like on that graph.
Yeah, it's a welcome change and one that we leverage in our clinic every day for our patients now.
Similar to you, the separation of the curves I expected. I would expect osimertinib to look good in a disease-free survival kind of an analysis. I am curious as to what will happen with the overall survival analysis as the data matures, but the degree of separation I did find quite shocking. And I think this is actually that perfect kind of a scenario where the classic question is, well, if it was you, what would you want? And academically, we say, well, we want to wait and see the data. But if it was me in this moment, I think in talking about 7th edition staging, stage 2, stage 3, the curves really separated in a way that was compelling enough that I think this is something to use currently. In the 1B setting, it was a little kind of less clear to me. What are your thoughts in kind of parsing through the scenarios in which you would use osimertinib, whereas you may not? And is there any distinction between the stages and how you have that discussion with your patients?
I tend to differ a little bit. The hazard ratio for stage 1B was 0.50. And so, I mean, there's a 50% reduction in the risk of recurrence and or death. I mean, if this were breast cancer, everyone would be all over it. So I tend to consider my 1Bs eligible for this. There's a question about whether patients should get both chemotherapy and osimertinib. Remember, chemotherapy is the only strategy thus far that has improved overall survival in the adjuvant space. So I tend to offer that to patients. So, if they're 1B through 3A, I tend to offer this. And, there are some pros and cons to this trial. As you mentioned, we haven't had OS yet. There are a high percentage of patients who didn't get adjuvant therapy. I don't think we have time to talk about costs and the financial toxicity here, but there are considerations that don't make this an absolute for all patients, but certainly one that I consider for my 1Bs through 3As.
Yeah, that is an important statement as to the adjuvant chemotherapy portion. And if I remember correctly, actually, there were more patients, or at least numerically, within the 1B group that did not get adjuvant chemo. I still see adjuvant chemo as being extremely important to this group. It does tend to be chemosensitive. Can you just speak a little bit about that? Do you still see chemo as being important? You're asking that question, it sounds like.
Yeah, I do. I think that chemotherapy is still the backbone. And again, it's been the only strategy that's improved survival in our early stage lung cancer. So I tend to push for adjuvant chemo and then tag on the osimertinib for 3 years planned. There are a few patients that are 1B that, maybe it's a little bit questionable the benefit of adjuvant chemotherapy or just offer osimertinib, but I think that's the exception, not the rule in my patient population.
So now transitioning to immunotherapy, we have in the adjuvant setting, Empower 010. Do you want to take us through that?
Yeah, so this was a very large study, once again, trying to translate the meaningful benefit we've seen with immunotherapy in advanced stage and leverage it in the early stage, similar to what happened with ADAURA. So this was a phase 3 study, a international study looking at completely resected 1B to 3A non-small cell lung cancer. And all patients different to ADAURA received adjuvant chemotherapy and then were randomized to 1 year of adjuvant atezolizumab every 3 weeks versus placebo. The primary endpoint here was progression-free survival. And the bottom line is there was a benefit for adjuvant atezolizumab in this study. But that benefit was, I think, more modest than we've seen versus the adjuvant osimertinib for the EGFR resected patients. We saw in the patients that were stage 2, 3 with a PD-L1 greater than 1%, there was a hazard ratio of 0.66. And again, we are desperate to find therapies that work in the adjuvant setting. We are desperate to move the needle in the adjuvant setting. Similar to ADAURA, we don't have OS yet. And the question is disease-free survival enough in this case? Again, this hazard ratio wasn't 0.21 or whatever the exact hazard ratio was in ADAURA. Nevertheless, the FDA looked at this data and specifically looked at those patients that were stage 2 greater than 1%, and that was the most meaningful benefit, and approved this. So I would say again that if patients have a PD-L1 greater than 1%, they're stage 2, 3 resected, I would consider offering this even though we don't have OS yet.
As you point out, it was approved for greater than 1%, and that was really a pre-planned analysis. That being said, the greater than 50% really showed a pretty clear separation. And there's some question as to whether essentially that greater than or equal to 1% is really being pulled entirely by that greater than 50% group, and how meaningful the 1 to 49% group is. What are your thoughts on that? And does that shape your discussion in any way with patients?
If you look at the forest plot univariate analysis here, and the PD-L1 greater than 50, you saw the most robust hazard ratio, roughly 0.4. If you look at the 1 to 49s, it was 0.87. So the question really is it's similar to Keynote 042 in the advanced stage. Did the greater than 50% truly, drive the benefit here? I think the 1 to 49s is a discussion. It's not a slam dunk for me. I think the greater than 50 is certainly one that I would pull the lever almost every time. The 1 to 49s, again, I think it's more of a discussion that we do for a lot of scenarios, which is this shared decision making with the patient and explaining to them in a way that they can understand the benefit versus the risks of adjuvant atezolizumab.
And just some background for our listeners, Keynote 042, what you're pointing out is that trial really was driven. This is metastatic non-small cell lung cancer. The greater than 50% really showed a clear benefit to single agent pembrolizumab. The 1 to 49% a little more questionable, but the endpoint of greater than 1% with single agent pembrolizumab was positive, led to FDA approval as single agent. But that being said, to your point, in the less than 50% PD-L1 expression, I think a lot of people are using chemo plus pembro in the metastatic setting and not really swayed by the endpoint showing essentially greater than or equal to 1% as being a single agent pembro group. And so it sounds like you're highlighting some complexity to this. And in the adjuvant setting now with Empower 010, after finishing chemotherapy in that 1 to 49% PD-L1 expression, you're saying, okay, it was positive, but not as clearly positive. And therefore, this is a discussion point with patients in whether or not to include this, but not a clear cut definitely should do. Am I getting that right?
Yeah, again, another discussion where we don't have a lot of clear-cut answers, where patients' decisions should be individualized, they're nuanced, and it's a shared decision-making with the patient. They have to participate in this and understand the risks and benefits.
Now, in the Keynote 091, we don't have as much details on this yet, but this is pembrolizumab after having completed adjuvant chemotherapy. This is a positive trial, but any thoughts on Keynote 091?
Yeah, a little confusing here. We saw benefit, I believe, in disease-free survival, but some of the subset analysis were a little bit wacky. I mean, the benefit didn't look that great in the PD-L1 greater than 50%. EGFR mutant patients, I think, had a benefit, which we don't normally see. I think this still solidifies the use of adjuvant immunotherapy, but I got to say that atezolizumab is still, to me, the standard given the benefit we saw in sort of benefit in subgroups that have scientific rationale to have benefit. So I would say that adjuvant atezo remains the standard for me.
Yeah, it does make me wonder a bit about PD-L1 expression in itself. I mean, this has really been somewhat of a messy and not entirely consistent biomarker across different immunotherapy studies. I agree. I think a lot of people were a bit surprised that the greater than 50% in the Keynote trial did not show a far more impressive benefit than the overall PD-L1 expression group. What are your thoughts on that, just the PD-L1 expression as a biomarker for all of this? We've discussed how it is impacting the discussion within the Empower 010 data, within the Keynote data. Does this alter anything about your thoughts on PD-L1, or is it more that the Keynote seems like an outlier?
I think the Keynote seems like an outlier, but I think you bring up a good point. PD-L1 is not a perfect biomarker, but I think it's the only one we have right now. You have to remember that PD-L1 has heterogeneous expression among metastatic sites. So some sites may be more likely to have PD-L1 expression, whereas others may not within the same patient. It can be heterogeneous depending on where the needle is. I don't think it's perfect, but it's what we have right now and what we use. So I still think it should be integrated into treatment decisions, specifically in the stage 4 setting, and at least based on Power 010, it should.
Now let's transition to the neoadjuvant space. So we had the Checkmate 816 data. What were your thoughts on that?
Yeah, I think we know a couple things I want to say. Number one, before 816, we knew that neoadjuvant chemotherapy pretty much provides the same benefit that adjuvant chemotherapy does. And so we also know that you're more likely to receive all planned cycles of neoadjuvant chemotherapy versus adjuvant chemotherapy, at least based on some studies. So Checkmate 816 is building on this neoadjuvant strategy and looking at, once again, the addition of immunotherapy. So this was, again, a practice-changing study looking at resected 1B to 3A lung cancer with no EGFR or ALK alterations. And they were randomized 1-to-1 to either neoadjuvant chemotherapy versus neoadjuvant chemotherapy plus immunotherapy, asking the question, does the addition of immunotherapy with nivolumab provide any benefit with chemotherapy versus chemotherapy alone for resected lung cancers? And the endpoint here was complete pathological response, which is defined as no residual viable tumor cells in both the primary tumor and the sample lymph nodes. And interestingly and quite surprisingly, those patients who got neoadjuvant chemo IO had a complete pathological response of 24%. And in the neoadjuvant chemo arm, it was only 2.2%. There are some other nuances here that I think are important, that patients that were receiving neoadjuvant chemo IO were more likely to have a lobectomy, less likely to have a pneumonectomy. And there didn't seem to be increased toxicities, even surgical morbidities in the patients who got neoadjuvant chemo IO. And finally, I would say we're starting to see early cuts of event-free survival. Once again, a composite endpoint of recurrence and or death. And we're seeing that complete pathological response is starting to translate into outcomes. And so I think complete pathological response is an accurate surrogate here, and it's probably some underrepresented data in the past. We've seen, at least with neoadjuvant chemo, that complete pathological response and even major pathological response does translate into better outcomes. So once again, we don't have OS here. Quite exciting based on this data. And we were fortunate to lead this study at Hopkins. FDA approved it, and I think we're in good shape here. We're going to move the needle once again, and this will take some altered conversations with the surgeons once they receive these patients to send them to the medical oncologist first before they do surgical resection.
Yeah, I was impressed by the data, and I think that the pathological response in particular was very impressive. You've highlighted a lot of the strengths of this and the benefits that have been demonstrated. I think one question within that data was the number of patients that had surgery delayed or didn't get to surgery. Now, there may have been a bit of a difference between countries. That wasn't a statistical analysis, but just numerically. But can you take us through that? Is that a concern at all to you? Is there any nuance to that?
Jacob, correct me if I'm wrong. I don't think there were more delays in the chemo IO arm versus the chemo arm. I'm willing to be corrected here. Even if there was, based on the complete pathological response and based on what we're seeing here in terms of surgical morbidity, no difference, a better operation more likely in the chemo IO arm versus the chemo arm, I'm all in on this. I really am. And we were one of the early adopters of this, and we've already seen complete pathological responses now that this has been done. We've done it several times, and I would say that the real world data is starting to look consistent with what we saw in the study.
I completely agree with you. And someone who's getting neoadjuvant chemotherapy, including nivolumab, to me is absolutely recommended, barring the rare scenarios of not being able to give checkpoint inhibitor for whatever reason. But in patients who are surgically resectable, where a lobectomy seems absolutely feasible, early stage 2 type of a cancer, are you using neoadjuvant chemo-nivo in that setting, or are there patients where you're having the surgeon operate and then you're talking about adjuvant chemotherapy? And that's really the basis for my question about delays in the surgery. I think someone with stage 3A, those people should absolutely be getting neoadjuvant treatment, and therefore nivo should be a part of that. I wonder a little bit more, particularly in the earlier stages.
I think the challenge we have is with those never smokers where you think they are likely to harbor an EGFR and ALK. Those patients weren't included in the study and, biologically may not have the best benefit with immunotherapy, even with chemotherapy. And you've got to wait for the molecular results to come back. So those patients, I will tell you, we recommend going to surgery, and then hopefully we unearth an EGFR mutation and can deliver adjuvant osimertinib. Because we led the study and because we have a lot of experience with this, and both our medical oncologist, Patrick Ford, and our surgeon, Stephen Broderick, are on the paper. We've got a lot of experience with this, and we are trying, even for our stage 2s and certainly our 3As, we are recommending neoadjuvant chemo IO.
Before we get into the workflow of it, the Nadim studies, how do those add to the picture?
There was a Nadim phase 2 study and then a Nadim 2 phase 3 study. Just briefly, the Nadim study that looked just at resectable 3A and got 3 cycles of carboplatin, paclitaxel, Nivo, and then went on to surgery, were allowed to get adjuvant treatment. They did nivolumab for 4 months Q2 and then 8 months Q4. The complete pathological response for 3A was north of 50%. And I think this was probably a little bit an outlier here, because we have the Nadim 2 study that was presented at ASCO 2022, a randomized study looking once again at potentially resectable 3A and 3B by the 8th edition staging. They excluded EGFR and ALK, randomization 2-to-1 to the experimental arm of carboplatin, paclitaxel, nivolumab for 3 cycles versus carboplatin, paclitaxel alone. Patients in the experimental arm also get adjuvant nivolumab Q4 for 6 months. And interestingly enough, the complete pathological response, which is the primary endpoint, was 36%. And again, we're seeing that from the Checkmate 816 study, that may translate into event-free survival. The pathological complete response rate for just chemotherapy was 6.9%. So consistent data. And again, this just solidifies, I think, the neoadjuvant chemo IO story. It does recapitulate some of the data we saw with 816. So I'm glad we're seeing consistent signals across the board here for these studies.
Yeah, so I'm hearing you say that essentially patients with a new diagnosis, you're doing a quick analysis and trying to get rapid genomic testing, or if you suspect something likely actionable, you're then having those patients get surgery first and sorting that out, potential actionable based on the tissue. Is that right?
So I would say if it's an actionable mutation, specifically EGFR ALK, or if it's a never smoker where we suspect it, we would probably operate first and then offer chemotherapy plus or minus targeted therapy, or specifically osimertinib, depending on whether we identify an EGFR mutation.
Now, in the final little bit, I just want to look ahead. There's a lot going on now. We essentially have validated both targeted therapies based on the ADAURA data. We've validated immunotherapy based on the trials we've discussed. What are some trials happening now that you're particularly interested in?
Yeah, I think there are a lot of trials. One, looking at adjuvant ALK-directed TKIs for ALK-resected lung cancer, RET fusion-directed TKIs for adjuvant RET fusions. And then, perhaps more interesting is the neoadjuvant genotype-directed trials, that these basket studies that compile some of the lung cancer mutation consortium efforts, looking at neoadjuvant targeted therapies before surgery, EGFR, ALK, RET. The list goes on. It'll be interesting to see where these targeted therapies land in the neoadjuvant space or the adjuvant space, and what's the best way to use them.
Yeah, and I'll just take a moment to highlight the Alchemist trials. This is something I'll say I'm involved in. There is an ALK-directed adjuvant study related to that, and then I am the PI of ACHIO, or A081801, which is a randomized adjuvant chemo followed by Pembro versus chemo plus Pembro followed by Pembro. In both cases, Pembro is for 1 year. And one thing about this trial is it is the only adjuvant study that is enrolling patients prior to any adjuvant chemotherapy. A lot of these other trials we've discussed is essentially a population of patients who still qualify for a trial after finishing adjuvant chemotherapy, which is a sub-selected group and probably a better than what we'll call real-world outcomes in the trials we've discussed. But that does wrap up quite a bit that we've covered. I want to thank all the listeners for joining us. Ben, thanks so much for joining the discussion.
Thanks for having me.
This is Dr. Jacob Sands for In Discussion.
Thanks for listening to Medscape's In Discussion Lung Cancer podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on lung cancer.